Hello, everyone. My name's Hannah, and I'm here today to talk to you about my research, which involves using imaging and AI to identify traits of hypertensive disorders of pregnancy. So, today is going to be an interactive session. So, if you want to answer any of the questions in the chat, you can. And if you have any questions for me at the end of the presentation, then you can address them as well. So I'm going to tell you all a little bit about me. I'm from Birmingham. I was born in the West Midlands, and then I did my GCSEs and A levels like you. I then went on to do my Bachelor of Science in Biology with Psychology at Lancaster University. After my Bachelor of Science, I then went on to study my Master of Science in Human Physiology at Manchester Metropolitan University, and then my DPhil at Medical Science at the University of Oxford. So the DPhil is a 4-year course, and I'm in my final year. I've just submitted my thesis, and my plan is to go into research afterwards. So I'm going to go into the next stages of my research. Whilst I was doing my Doctor of Philosophy at the University of Oxford, I worked at the Cardiovascular Clinical Research Facility, which is at the John Radcliffe Hospital in Oxford. And there is where we did the research in women with hypertensive disorders of pregnancy. So we looked at them during pregnancy and postpartum, and we did a range of different clinical assessments, including imaging, such as magnetic resonance imaging and echocardiography. So in today's talk, we're going to have a brief overview of hypertension and hypertensive disorders of pregnancy. We're then going to look at how imaging can be used to explore different patterns of disease in women with hypertensive disorders of pregnancy. And finally, we're going to look at how AI can be applied in the future to improve outcomes for women with hypertensive disorders of pregnancy. So to start off, it's important to know a bit of background into hypertension, and we'll start off with blood pressure. So you might already know what this is, but as your heart pumps blood around the body, it pushes blood against the walls of your arteries, and the force that it applies is known as your blood pressure. So how is blood pressure measured? Well, we use something called a sphygmometer. We would wrap this around the patient's arm, and then you would squeeze it to pump it up, and then you would look and you would listen for a sound. And the first sound that you hear is called your systolic blood pressure. So this is quite a loud beating sound. And when this beating sound stops, this number is called your diastolic blood pressure. So systolic blood pressure is when your heart contracts and forces blood out of the heart into the body. Diastolic blood pressure is when the heart is relaxed between beats and is filling with blood. So, a quick question for everyone. What level do you think that the National Institute of Care and Excellent guidelines recommend for keeping blood pressure below to stay healthy in general? So, do you think it's A, 115 over 75 millimeters mercury, 120 over 80 millimeters mercury, C, 135 over 95 millimeters mercury, or D, 140 over 90 millimeters mercury? So, I want you to put your answers in the chat. And what do you think to stay healthy? Okay, we've got quite a few people saying B. So it seems a lot of people are saying B, a couple of people saying C. So this is to keep your blood pressure below to stay healthy. So you want it below this number. Any other ideas? Okay, so we'll go over the answer. So the National Institute for Care and Excellent guidelines recommend that for healthy blood pressure, you keep it below 140 over 90 millimeters of mercury for adults under the age of 80 and below 150 over 90 for those aged 80 and over. So a lot of you put B, that is the ideal amount that you would like your blood pressure to be at, but you ideally want to keep it below 140 over 90 in order to be free from disease. So now I want you to answer in the chat, what do you think happens when healthy blood pressure is not maintained? So what do you think happens when your blood pressure is too high or too low? What kind of problems might this cause? Yep, really good answer from Ayla. Damage to the artery tissue. Hypertension, yep, exactly, good. Heart issues, really good. Any other ideas? Yeah, a lot of you putting strain on the heart and arteries and heart attacks and blood clots, really good. What about if your blood pressure is too low? What would happen? Yeah, exactly. Fatigue, you might feel faint, dizziness, really good answers. Perfect. So what would happen if you have too low blood pressure or too high blood pressure? Well, if you have low blood pressure, you might feel dizzy, faint, blood, vision, confusion, fatigue. And if you have too high blood pressure, you might get chest pain, heart palpitations, headaches, seizures, and end organ changes as well. So there's a lot of different symptoms that you can get from having too low or too high blood pressure. So now we're going to go on to what are hypertensive disorders of pregnancy. So a hypertensive disorder of pregnancy is defined as a woman who develops high blood pressure during their pregnancy. So this involves having systolic blood pressure over 140 millimeters of mercury and diastolic blood pressure over 90 millimeters of mercury. If this occurs before 20 weeks of gestation, it's termed something called chronic hypertension. And if it happens after 20 weeks of gestation, it's known as gestational hypertension. Women who develop gestational hypertension can then go on and develop something called preeclampsia. So you might have heard of this. This is where they have high blood pressure, but they also have end organ damage. Particularly, it seems to occur in the kidneys. So they show high levels of renal markers, which are indicating some kind of dysfunction is going on. Women who develop preeclampsia can also go on to have eclampsia. Eclampsia is where they present with neurological symptoms such as seizures during pregnancy, and they can also develop something called HELP syndrome. So this is known as hemolysis, elevated liver enzymes, and low platelet syndrome. And this, as the name suggests, is where they have elevated liver enzymes and something's going wrong within that organ. So hypertensive disorders of pregnancy affect 5 to 10% of pregnancies globally, affecting around 20 million. So it's a lot of women that are affected. And it affects different subgroups differently. So gestational hypertension affects 6 to 7% of women, preeclampsia 2 to 8% of women, chronic hypertension 1 to 5% of women, and then a very small minority can develop HELP syndrome and eclampsia. In the UK, women with hypertensive pregnancies are affected in around 8 to 10%, and that affects around 70,000 women annually. Again, these can be broken down by subgroups. So gestational hypertension, 4.2 to 7.9%, preeclampsia, 1.5 to 7.7%, and chronic hypertension, 0.6 to 2.7%. Again, with a small minority of women having HELP syndrome and eclampsia. So what happens to a woman's blood pressure during healthy pregnancy? Well, in the first trimester, a hormone is secreted called progesterone, and this causes the blood vessels to relax. As a result, your blood pressure actually drops during healthy pregnancy. In the second trimester, your circulation expands, the heart pumps more, and the arteries remain dilated, and your blood pressure is at its lowest at 20 to 24 weeks of pregnancy. In the third trimester, your blood volume peaks, and then your blood pressure gradually returns to your normal, healthy pre-pregnancy levels. But what happens to a woman's blood pressure during a hypertensive pregnancy? Well, in the first trimester, the placental blood vessels, so these are the blood vessels which attach to your placenta, and the placenta supplies the fetus with nutrients and blood during the pregnancy to help them develop. If these don't remodel properly, then it leads to poor blood flow and vasoconstriction, which involves narrowing of the blood vessels. The blood pressure then remains high, or it doesn't show that normal decrease during pregnancy. So rather than decreasing as it normally would in a healthy pregnancy, it just stays high. In the second trimester, the placenta may not receive enough blood because the uterine arteries haven't remodeled properly, and therefore the blood pressure remains high. And again, it may remain high in the third trimester or even peak, and this is when the women and fetus start to experience risks. So some of the direct risks of a hypertensive pregnancy are edema. This is where you get swelling in the limbs. You also can get placental abruption. So this is where the placenta is separated from the uterus and you might get internal or external bleeding. You can get premature birth, stillbirth, and intrauterine growth restriction, where the fetus doesn't grow as it normally would. And you can also get end organ changes and even mortality in some women. So now I'm going to specifically talk about the end organ changes that women can experience during the pregnancy. So within the heart, you can get something called left ventricular hypertrophy. So this is where you get increases in the muscle and the thickening of the left ventricular walls, which over time would cause stiffening of the heart, and you don't want this. You can get concentric remodeling, where you get abnormal remodeling of the heart, diastolic dysfunction, so the heart's not pumping as it normally would, and arterial stiffness and afterload. In the kidneys, you might get changes in kidney volume, increases in proteinuria, micronuria, creatinine, and urea, which is a sign. So basically, you'll end up with extra protein in the urine, which you don't normally have, which is a sign that the kidneys aren't filtering as they normally would. And you get something called reduced estimated volume filtration rate. So this is estimated volume filtration rate is a normal sign of healthy functioning kidneys. So if you have a reduction in this, it suggests your kidneys aren't functioning as they normally would. And you also get reduced renal perfusion, so reduced blood flow to the kidneys. Within the brain, women can experience signs such as headaches and visual disturbances. Some women, particularly in eclampsia, develop seizures, and they might show white matter lesions. So these are little markers on the brain, which again indicate that something might not be quite right. In the liver, you have elevated levels of enzymes related to the liver's function, hepatocellular injury, subcapsular hematomas, and hepatic rupture as well. So you can see that there's a range of different changes that are occurring across the different organs, which wouldn't normally happen in healthy pregnancy. Women with hypertensive disorders pregnancy are also at long-term increased disease risk compared to their normotensive counterparts. So, for example, women with preeclampsia are at 2 to 5-fold increased risk of developing high blood pressure later in life after pregnancy, and 2 to 4-fold for women with gestational hypertension, compared to women who would have a normal, healthy pregnancy with normal blood pressure. They're also at 1.5 to 3-fold increased risk of having a cardiovascular event after the pregnancy. One study has shown that 1 to 2% of patients can develop hypertensive retinopathies. So this can include narrowing of the arteries and the veins, and even visual loss. 2 to 5-fold higher risk of developing end-stage renal disease compared to normotensive counterparts, and 1.5 to 2-fold for women with gestational hypertension. And finally, the studies have shown that women have a 2 to 3-fold increased risk of developing vascular dementia and stroke after a hypertensive pregnancy compared to women who have a normal pregnancy. So what I'm trying to do in my research is look at whether the increased long-term disease risk is due to pregnancy or whether it's due to pre-existing disease. Now, this is really difficult to disentangle, but we kind of have 3 hypotheses for this. So firstly, our first hypothesis is that women who have hypertensive disorders of pregnancy are on a faster trajectory towards disease before they even have the pregnancy. So they might have some kind of pre-existing damage, which then explains the later disease. Our second hypothesis is that pregnancy itself induces dysfunction, which then causes a faster trajectory towards disease. So they kind of take a hit during the pregnancy, and then this puts them on a faster trajectory towards disease. And then our third hypothesis is a bit of a combination of both. So the women with hypertensive pregnancies may already have some kind of underlying dysfunction within them that causes them to have problems during pregnancy. And then pregnancy adds an additional insult, which then again speeds up their trajectory towards later disease. And this is why they're at higher long-term disease risk. So the most likely hypothesis is the third one. So they take a hit during pregnancy, but they already have some kind of underlying dysfunction. And why is it important to know this trajectory? Well, if we fail to control target organ damage early, it may lead to an accelerated trajectory towards disease. And so we can try and reverse the insults through interventions early, and then we can prevent that later disease, and therefore reduce the overall disease burden, reduce the burden on the NHS, and reduce the hospital stay that these women have to have. So currently, there are some interventions that are being trialed. There's some studies which are looking at optimizing blood pressure control using antihypertensive medication. So ensuring that the hypertensive medication is controlled within the right levels for a particular woman. And also by increasing the amount of normal pregnancy supplementation. So, for example, women have folic acid during healthy pregnancy, and they're told to take these tablets in order to maintain their blood pressure. So, by increasing the amount of supplementation that they can have, it might reduce the number of women that have hypertensive pregnancies. Now, I'm just going to talk about a particular trial. So this was called the POP-HT and SNAP-HT trial. And what they did was compare tightly controlled blood pressure medication during the postpartum period to normal healthy care in 220 women. So what they did is they asked women in the intervention group to measure their blood pressure using a wireless blood pressure monitor that they provided. They were asked to take 2 readings 1 minute apart every morning, and then through Bluetooth, they sent the information back to a doctor or a physician. And if their blood pressure readings were too high, then the physician could tell them to adjust their medication. So this meant that they could tightly control their blood pressure every day, and rather than just being sent off with the same amount of blood pressure medication to have. And overall, this trial found that there was a significant reduction in systolic and diastolic blood pressure in 6 to 12 months postpartum. So this is 6 to 12 months after the pregnancy. The intervention group had significantly lower systolic and diastolic blood pressure compared to the normotensive group. And they also found that this difference remained up to 4 years postpartum. So just simply by tightly controlling blood pressure, they were able to control the blood pressure for a long period of time afterwards. The trial also looked at the effect on cardiac remodeling. So they found that the intervention group showed lower relative wall thickness in the heart, lower left ventricular mass, lower end diastolic and systolic volumes, higher left and right ejection fractions, improved diastolic dysfunction, and reduced left atrial volumes. So overall, this showed that there are benefits of the intervention on cardiac remodeling, both short and long term. And so it suggests that perhaps there are interventions that can be used to reduce the burden of hypertensive disorders of pregnancy. And this is a little graph showing how we can prevent the accelerated trajectory to long-term disease by preventing cardiovascular disease in these women. So now I want you to put in the chat, is it possible to intervene to prevent disease progression in other organ systems following hypertensive disorders of pregnancy? So I'm interested to know your ideas. Do you think it is possible to intervene early and prevent disease progression, or do you think that it's not possible? Maybe the damage is already done. Okay, a few people are saying yes. Yes, but depending on the person, good. Yeah, that's a good answer. So it might be possible, it might not be possible to prevent it, but it might be possible to slow the disease down. And also depends on the pre-existing conditions of the person. It might depend on the situation and the disorder. Maybe there's other suggestions for interventions, which is good. Yeah, and also it depends on how easy the organ system is to heal. So it might be easy to change remodeling of the heart, but it might not be so easy in other organs. And yeah, again, it depends on the severity of the hypertensive disorder. Really good. And yeah, I think that's a really good point that Laura's made. It might be hard to know when to step in if there aren't many symptoms. So sometimes the symptoms of a hypertensive disorder go down after the pregnancy. So, for example, their blood pressure returns relatively to normal. So you might not know whether they actually have any organ damage unless you scan them using imaging. And so that's a really good point. It's hard to know who actually is already got dysfunction within them. And so there might be ways to screen different women. And yeah, exactly. It can depend on genetics as well. Okay, really good answers overall. So now I want you to discuss in the chat, when do you think the best time to intervene in women with hypertensive disorders pregnancy is to prevent later disease? Do you think it's before pregnancy, during pregnancy, or after pregnancy? Okay, yep. A lot of people are saying before pregnancy. Some people are saying during pregnancy. Not many people saying after pregnancy. Yeah, exactly. So as soon as possible before and then monitoring throughout is a really good answer. Yeah, and also when you first identify the symptoms, exactly, really good. And also that's a good answer as well. So if the woman already has an underlying condition, so some people have renal dysfunction before pregnancy. If you already know about that, you might be able to prevent it before the pregnancy. So that's really good. In other women, they might not show any dysfunction. They might be really healthy. So you might want to give them an intervention after pregnancy. And yeah, you can advise the patient on what might happen during their pregnancy. So that's a really good answer as well. Brilliant. So I think a lot of you are on the same lines that maybe before pregnancy and during pregnancy. So how do we know when to intervene? How can we research this? Well, to know this, we need to understand exactly when the end organ changes are occurring. And we can do this through imaging. So there's many different types of imaging modalities that we can use. One is MRI, and this is a really good imaging technique to use. It's really gold standard, got high resolution images, and you can see things in 2D and 3D, and you can look at the structure and function of different organs. Another one is CT scans. These can be really quick scans. They're used in medical situations, but sometimes used in research as well. You can do X-rays. So X-rays aren't as good quality imaging as MRI, but they are used in some cases. Echocardiography. So this is really good for looking at the function of the heart, and it's really simple, easy to use. So the patient doesn't have to have as much preparation as they might need to for an MRI or a CT scan, for example. And another one is microvascular imaging. So we can take pictures of the ears and the eyes, and we can look at the different blood vessels within the ears and the eyes to see how they are functioning and look at the structure of them as well. So this is an example of how we can use imaging. So this is an example of a magnetic resonance scan. Can anyone tell me in the comments what organ this is? Does anyone know what organ this is a picture of? Okay, someone suggested the eye. It's not the eye, not the liver. Okay, nope, it's not the kidney, not the brain, not the pancreas. Yeah, well done. So, a couple of people have got it. It is the heart. So, this is a slice by slice view of the heart. So, essentially, what we can do with MRI is take pictures of each slice from the apex all the way down to the base, and you can look at it during end diastole and end systole. So, you can look at different stages of when the heart's contracting. And then, what you can do is manually contour and draw around different sections of the atria and the ventricles, and then you can measure the total volume of the heart. So this one might be a bit easier. Does anyone know what organ this is? Okay, not the brain. We have got the spinal cord in the images, but the one in red that we're looking at. So what is the image showing? It's not lungs. Yeah, well done, Ethan and Bobby. This is the kidney. So again, you can do the same as the heart. You can take MRI pictures of the kidneys. You can then contour around different sections of the kidneys and you can calculate the total volume. So we have software which can interplay between each of the slices of the kidneys and calculate the total volume of the kidneys. We can then compare women with hypertensive disorders of pregnancy to women with normotensive pregnancies, and we can see whether their volumes are smaller or larger than the normotensive counterparts. So this is an example of the heart, and here we are measuring the thickness of the wall. So this dark bit here is part of the ventricle, and what you can do is measure the distance between the lines, and you can measure how thick the ventricular wall is. So if a woman is showing a thicker wall, exactly. So someone in the chat's written the ventricles and the myocardium. Really good. So you can measure the thickness of the myocardium and you can see how thick it is. And again, compare it to normotensive women. Okay, so this one is the kidneys, and here we can look at something called corticomedullary differentiation. So corticomedullary differentiation is the distinction between the cortex and the medulla. In a healthy person, they should have really good corticomedullary differentiation. In someone who is not so healthy, there is less of a distinction between the medulla and the cortex. So the cortex is the outer yellow part here, and then the medulla is the red part. When someone has poor corticomedullary differentiation, these two sections become really blurred and undistinct. But if someone has healthy corticomedullary differentiation, you should clearly be able to distinguish between the cortex and the medulla. And what this shows is that when you have healthy corticomedullary differentiation, the filtering components of the kidneys are working correctly and they're not blurring together. Okay, anyone know what this organ is? So this one might be more obvious. Yeah, brilliant. The brain. So again, you can take MRI, you can take CT pictures of the brain, and you can calculate total volumes of the brain. You can also look for white matter lesions. So the white matter lesions are these white spots here, and they can show, again, disease in patients. And what about this organ? Does anyone know what this organ is? Yeah, a lot of you have really quickly got that. This is the eye, this is the retina. So what we can do here is we can take pictures of the eye, we can then input into different software, and then we can use the software to identify the central veins and arteries, and we can look at the distance of them to the optic disc. We can measure things like the size of the vessels and the arteries and the number of the vessels and arteries, and we can compare the thickness or the diameter of the veins and the arteries in a ratio. And in women who have, for example, in women with hypertensive pregnancies, they can sometimes show arterial and venular narrowing, which is an impact of generalized vasoconstriction because of the high blood pressure that they are showing. So this is another really good way of imaging And again, something good about this is that you can take one quick, simple image, and then you can use that to look at a woman's health just from a simple, non-invasive image. So by taking these images at different time points across a women with hypertensive pregnancies life course, we can see how they progress and at what point different diseases are occurring. So these are just some trajectories which suggest how the different organs might progress over time. So for example, in the kidneys, women with hypertensive pregnancies show a spike in proteinuria during pregnancy, but their total kidney volume seems to be smaller than in women with normotensive pregnancies. But postpartum, their proteinuria returns to normal levels, and they still show this reduction in total kidney volume. So, given this idea, we would maybe intervene earlier with women who might have kidney failure later in life to prevent the later progression towards disease. In the heart, obviously, women with hypertensive pregnancies show increases in left ventricular hypertrophy. These don't completely return to normal, and then they're at high risk of cardiovascular disease later in life compared to their normotensive counterparts. But they can show some beneficial remodeling, so maybe it's better to intervene later postpartum in order to prevent the later cardiovascular disease. In the retina, so the women seem to show a decrease in the arterial and venular caliber, and then they're at higher risk of developing hypertensive retinopathy later in life. So again, it might be better to intervene earlier in these women. And the brain, we don't know yet at what time point we should intervene. But again, if we can gather as much evidence as possible and understand the trajectories and what is happening at different time points, it might guide us on when is the best point to intervene in these different organs. So now I want you to discuss in the chat, how could we maybe apply artificial intelligence to improve imaging and risk prediction for women with hypertensive disorders of pregnancy? So how might we apply artificial intelligence to the different imaging techniques that I've just talked about to improve risk prediction for women with hypertensive pregnancies? Yeah, exactly. That's a really good answer from Ayla. You might be able to use artificial intelligence to analyze images and to recognize differences in images that aren't seen in the healthy organs. Really good. Yeah, exactly. So maybe to pick out areas of interest on the images and to analyze them or look for specific patterns. Yep, compute predictions, really good. Yeah, exactly. So you might be able to collate all the imaging techniques together to calculate an overall risk and look at trends. Yep, really good. And yep, use AI to predict risks from health records, so early detections. That's really good. And predict, yep, brilliant. Yeah, exactly. So combining the patient history with the imaging, that's very good. And maybe able to spot future problems. Yep, personalized management and accurate risk stratification. That's a really good answer. So making it personalized to each individual and to each organ. Yep, good. Well done. So prioritizing imaging in general routine checkups and communicating with the patients. So using AI, we might be able to communicate better with patients. Yep, exactly. Really good. And predicting long term. Yeah, exactly. So you might be able to use it to predict long-term outcomes as well. So a lot of you are all on the really right track of thinking about what kind of future with AI might have in imaging and risk prediction for women with hypertensive disorders of pregnancy. So I'll now go over what kind of things we can do to improve imaging and risk prediction. So firstly, we can enhance imaging acquisition and analysis techniques. For example, we manually contoured the kidneys and the hearts in using the MRI. And so instead of manually contouring them, we might be able to develop techniques which mean we don't need to manually contour them. Instead, we might have machines which can automatically carry out the contouring for us, which would then mean that we can increase the number of patients that can be imaged and also reduce inter-observed variability. So one difficulty that we have with manual contouring is that one person might contour an organ one way and then someone else might contour it differently. And so that can cause difficulties because they might accidentally contour it wrong and then diagnose a patient with something they don't have. So if we can have AI do it, then there might be less problems, less inter-observer variability. And also it will save the amount of staff that you need, and it might reduce costs. So it would be really good to have AI be able to enhance imaging acquisition and analysis techniques. The second thing that we can use AI to do is to develop risk prediction models to integrate pre-pregnancy characteristics with later life organ-specific phenotypes. So using their pre-pregnancy characteristics, so maybe their type of pregnancy, characteristics of their delivery, all of these, if we integrated them into a particular model, we might be able to then predict later life organ phenotypes. And this would then improve identification of the women at greatest risk of adverse disease outcomes following hypertensive pregnancy. And then therefore we could follow these particular women up and also maybe prevent disease in these women. And finally, we might be able to create risk scores to help the women to understand their current stage of disease progression, understand stages of disease in different parts of the body. So it might be that their heart is more diseased than their kidney, and so they can have a score for each part of the body. This would also help aid interpretation and communication to patients. So the doctor would be easily able to explain what their risk score is and what this means for them and for their particular organ. And then it might help to improve the treatment and management of their condition. You might also be able to track scores over time to see if the interventions have helped to reduce their risk scores and to improve their outcomes. Okay, thank you for listening. Has anyone got any questions? Okay, you can put them in the chat. Firstly, Schiffer has said, what examples are there of pre-existing damage which can cause hypertension in pregnancy? So that is a really good question. So one of the reasons for hypertension in pregnancy might be kidney dysfunction. So women who already have smaller kidney volumes might then go on to develop preeclampsia. It might be women who have had a kidney transplant, for example, or unilateral kidneys. So they've had a kidney removed, and therefore that could be a reason that they develop preeclampsia. It could be something wrong with one of the other organs, for example, their heart. So maybe their heart isn't pumping as efficiently as it normally would, and then therefore they are trying to make up for that by their blood vessels constricting. Or it might be something to do with the placenta. The placenta has a big role in hypertensive disorders of pregnancy, and so having placental dysfunction could then cause all of the other complications. It's not known the exact cause for every single woman, but there seems to be a range of different factors that contribute. It could be a lot of cellular damage and different really endothelial factors which contribute. Okay, and someone said, can you please go back to the first use of AI? So yeah, I'll just explain that. The first use of AI is enhancing image acquisition and analysis. So again, what we normally do when we image is we manually contour each of the organs. So we take pictures of them using the MRI scanners. We then contour them, and then after that, we could calculate the volume of the kidney, or we could calculate the thickness of the walls of the heart, for example. So by using AI, we can try and automatically contour the images rather than manually doing it. So someone said, what is it that gave you the inspiration or certain interest in hypertensive pregnancy disorders? So I think when I was at school, I didn't entirely know what I wanted to go into. But then when I went into university, I was really interested in the human body, and I found the heart really fascinating because it's just such an amazing organ, which can is interrelated with all the other different organs. And then from that, I then found a research group which was looking at imaging, and I was really interested in looking at the human body and imaging. And so I ended up going into this research group, and their kind of theme was hypertensive pregnancy disorders. So then I joined that group, and I found it really interesting. So kind of continued with that. Okay. So what do you mean by how diseased organs are? So yeah, again, a good question. So different organs are obviously affected differently by hypertensive disorders of pregnancy, and I mean, you can describe it as disease, but it's really there's changes that are occurring within the organs. So within the heart, it's not functioning as it normally would. So it's not pumping as efficiently, for example, or the kidneys, the filtering components aren't working as they normally should. And yeah, some good questions about white matter in the brain, and also about grey matter as well. So yeah, there are a lot of studies which have shown that if with women with white matter lesions and with reductions in their total grey matter and white matter volumes, postpartum do have changes in their memory, and they do worse on cognitive tests. So there are a lot of studies. So if you're interested in reading them, there are a lot of studies out there which are shown that women with hypertensive pregnancies do perform worse on cognitive tests. So that's quite an interesting question. Yeah, and of course, there's always going to be problems with AI and errors that occur. And so we can't completely rely on AI. There will probably always have to be a person who analyzes the AI as well. So it might be that AI does enhance imaging acquisition analysis, but also there'll have to be a person monitoring that. It's like with the imaging scans, we can't completely have a computer that takes the images because we need a person to direct where the images should be taken and to focus on something. So it might be that we can't always use AI to completely get rid of human input. And yeah, there might be examples again. So somebody's asked where the AI model cannot interpret or correctly predict. So again, you do need human input as well as AI. Yeah, and someone has asked, is hypertension in pregnancy most common in women of any specific ethnicity or background? Yeah, there is women who have uh, higher risk factors for developing hypertension. So women from poorer incomes and lower income backgrounds are more likely to have hypertensive pregnancies. People who have twins are more likely to develop hypertension during pregnancy, and from Afro-Caribbean backgrounds as well are more likely to have a hypertensive pregnancy. And yeah, so someone's asked an interesting question, which is what effects does hypertension have on the baby? What does it cause long-term problems? So again, there's a lot of studies which are looking at the effects on the offspring, and some studies have shown no long-term effects on the offspring, but it does depend on what happens during the pregnancy. For example, if the baby is born preterm, there's a lot of studies which are showing that babies born preterm have long-term problems, for example, cardiovascular problems, reduced exercise efficiency. So hypertension can it can affect the fetus in some ways long term. Okay, so someone's asked a really good question. How do you think it's best for AI to be integrated in risk analysis? How do you balance this with the need for confidentiality and the risk of us becoming over reliant on AI and missing out important red flags? So yeah, again, I think it is important that you do have humans monitoring the AI, ensuring that the AI is doing it efficiently. So there'll always be the need to have humans and AI working on something. In terms of confidentiality, it's really important that all the data is anonymized, and this can still be possible with AI, and uploading it to high compliance servers where people cannot access it. So there are ways of ensuring confidentiality even with the use of AI. And yeah, there may always be inaccuracies with AI, and again, it's just ensuring monitoring it. So a lot of similar questions regarding the AI. Yeah, someone's asked what group of professionals would be working with the AI. Is it something that you're currently working on? A lot of people in my research group are working with AI and machine learning models, and they're trying to develop risk prediction and scores in the future. So my department are currently working on something called the Hyperscore, and this is where they are integrating a lot of pregnancy data with AI to predict things in the future. So it is something that my group are working on.